When I was asked to speak to the committee today regarding the Medicare regulations, Lynn Kuhn asked me to speak from the business office perspective because I get to deal with all of them across the board, from admissions, talking to patients, from a compliance standpoint for billing, auditing, and then looking at business applications going forward. One of our largest challenges in cancer care is the emerging technologies and the amazing advancements that have come along. With that are some capital investment ventures that come out. One of our hardest things with looking at capital ventures and expanding our services is tied to emerging technologies. We offer radiation therapy services, and emerging technology over the last several years has been stereotactic radiosurgery. Stereotactic radiosurgery is for the treatment of lesions, tumors, and other radiation therapy needed services. It has been FDA cleared for the entire body. The service line to start out is $4 to $5 million. As a small business, we're looking at our patient population, radiation therapy, and that this service can cover the entire body. So you're fixing to make a business decision based on that information. Next comes the G codes. How are we going to bill for it? How are we going to pay for it? CMS has outlined some G codes for stereotactic radiosurgery. Unfortunately, they're only for the hospital, not for outpatient. In working through the coalition and various organizations, those codes were opened up for the outpatient setting, local carrier priced. So we said, that's great. So we called Trailblazer and we said, we'd like to purchase the system. We're looking at the G codes, it's carrier price. Can we have the price that you're setting for this payment? Nope. Buy the equipment, submit your claims individually, and we'll determine reimbursement on a case-by-case basis. We escalate the calls, we send letters, and we still are not at that platform. The inconsistency of the regulations being applied is difficult for us to manage. 6 other states have published what the states are going to pay for the G codes. So it is a daunting task for a small business to look at making a substantial investment to better the patients, to keep it in an outpatient setting without having to duplicate those services in the hospital setting. But we're stuck here. So the emerging technologies is really an interesting gambit for us to look at, and it's part of our ongoing viability as reimbursement is cut for drugs and ongoing services throughout the system. And that leads me to probably one of the other federal regulations that seems to be going through a significant change for cancer patients, and briefly like to touch on erythropoietin stimulating agents. Unlike an emerging technology, that is a technology that has been around for a long time. It's a drug that is a support drug and helps us continue to give chemotherapy treatments. CMS has recently limited, outside of the FDA guidelines, how we can administer that drug to our patients. We are abiding by that. Patients are having delayed chemotherapy treatments. We can define a direct correlation to reduce prescriptions for chemotherapy. And one of the hallmarks of good cancer care is maintaining on schedule correct dosing for your patients. So the ESAs are very troubling. The patients don't understand it. They feel better with the product. They know that they're able to tolerate the treatment and finish more quickly. The negative impact to the patients is many of our patients are saying we'd like to pay for it out of pocket. So we're filling out the appropriate paperwork. We're talking with them. And many of our patients are going there. The other thing they're asking us, are the other payers requesting the same guidelines? No, they're not. CMS has taken a very bold step here and is the only payer that is limiting the guidelines for the use of ESAs for chemotherapy-induced anemia. Unfortunately, a lot of our patients are now looking to the Medicare Advantage plan. From an administrative burdensome standpoint, the Medicare Advantage plan transition has been a major stumbling block for our practice. Patients are signing up. They are having salesmen come to their offices, come to their homes, telling them it's just like Medicare. It's going to pay all your same benefits. What they don't understand is that they are no longer part of the Medicare Part B program. They are now part of Medicare Part C, and they have just forfeited their dual eligibility rights. So if they don't purchase a product that, again, covers them for the Medigap information, they are not going to be covered, and 20% of chemotherapy is a substantial dollar amount. They cannot afford it. Even more troubling, if they are dual eligibles to Medicaid, Medicaid will not make the 20% coinsurance payment because it's no longer Medicare Part B. We worked with a nationally recognized carrier, Humana, for 6 months trying to resolve these issues. Texas Medicaid finally sent us a letter back saying it's not Part B, it's Part C, and we don't cover it. We were stunned. Our patients are stunned. So they're disenrolling as quickly as they're enrolling. Thank you for your time.